هلا بعمي، ايه حزدون البيت. هلا بعمي حمزة، هلا. هلا بعمي عمار. Please Alex, send again. يا هلا يا هلا. تسمعوني؟ سامعيني؟ يا هلا يا هلا، منورين والله. Perfect. Just wait Alex for a second. Great. Okay. حبيبي دكتوري، أشكرك. Okay. Hey Alex.
Hassan, hi, I'm sorry about this. I don't know what happened, really.
Welcome back again. We missed you.
I miss you too, guys.
Let's
Okay,
go.
so
I have so many questions about this case. This case is very interesting one.
really,
So
I want to
I'll
hear
take a
them.
lot of time in my questions more than normal.
Okay, awesome.
Yeah.
So should I go on?
Yes,
Okay.
go on. I will turn off the comments again, guys, okay? I'll turn it off so you can see the screen much better. Okay, then I'll turn it on at the end. Okay, go, Alex, please. Go ahead.
Okay, so that's the final situation, and she was really happy, and I was happy with her, and that's the most important thing, just to make someone happy.
Yeah.
Okay, that's also a very interesting case. That's also a case out of the box. As you can see here, we have an old composite veneer on tooth 11. I think she had this veneer for something like 10 or 15 years, and she wanted to change it. Now, as you can see, tooth 21 has a labral proclination, okay? So as you can see from the lateral here, it's much more towards the labia. Now, this is the initial smile of the patient. And let's see the difficulties that we have. First of all, we have some difference in the zenith levels. As you can see, this one's much higher than this one. So this one looks always smaller than this tooth.
Yeah.
So we have two misaligned teeth. Tooth 21 has a labral proclination and tooth 11 has a palatal proclination. So what do we do? So I think that the most common thing to do would be to do two centers, right? Two veneers. But I really love this teeth. I mean, can you see the incisal edge, all the pallescence, the halo, and all the forms and the curvature? I loved it. So I didn't want to touch it. And I say, okay, let's try something else. So I decided to only do tooth 11. So at this moment, I've done my isolation, okay, with the rubber dam. It's a Nictone, it's a heavy. That's 212 clamp from Hu-Friedy. These are some Teflon tapes to isolate the adjacent teeth. And right now I have removed the old composed veneer. And as you can see, I have a lot of enamel, and only this one here is a bit of a dentine. So I'm really happy. I know I'm gonna have an extra good bonding. So I start and I don't have a wax up, okay? So I have to do this freehand. So I also have to remove the clamp. So what do? The first thing I do is I make a composite mound on the cervical area to keep the rubber dam in place. So you make something here like this, so you can keep your rubber dam really apically, so you can work here. I usually place a dentine composite here because you know that the cervical part has a really, really thin layer of enamel. So that's, I think, 0.4 or something, if I remember well. So I place dentine here. Then I use a metallic precurved matrix to form the distal ridge with enamel. So I'll make the mesial and the distal ridge with enamel. And as you can see here, this is much longer than this one. So at this moment, I use a burr to shorten it a bit because I don't have a wax up, okay, and I have to be extra careful. So what's my personal choice? I almost most of the times I use the bleaching from IPS Embers Direct. That's the enamel because it has a beautiful opalescence. And what is really important to do if you have an extra bright color, such as a bleaching color, a bleaching shade, which is really white, you have to have semi-translucency and you have to have opalescence in order to be more natural. And I like big contrasts. I mean, the dentine, I think it was A1. So dentine A1 and the enamel is bleach. That's a big contrast, which gives depth to your restorations. So right now I'm creating some lobes. I made 4 lobes. They're a bit irregular. You have to make the lobes a bit irregular. So we have enamel, and dentin for the lobes. So how do we go on? We use something semi-translucent between the lobes, and that is the opal trans. That's a flowable composite that gives opalescence and translucency at the same time. So it's really useful. And then you cover everything up with a final layer, which is enamel. And I'm just saying that I have some glycerin here because I always do the final polymerization with glycerin. And for the reason that you have already told us, Hassan and Celine, in the previous webinars. So that's the final enamel layer. And that's what I was talking about before. To get a smooth final layer, it's really important to use a tool that will help you with that. And you have to get rid of micro deficiencies that tend to trap silicon remnants from the polishers. And a few things about the opalescence. I don't know if you're interested about the theoretical part, but opalescence occurs mainly in enamel. Okay, so it's an effect when you can see our eyes detect only the reflected light, which are the short waves, so the blue, the gray, and the violet, and that's the opalescence. And counter opalescence is the phenomenon that causes amber, orange, and red gleams to appear. And this is especially evident under transmitted light and when teeth are in occlusion. And this is the final situation. And as you can see, you have a much smaller tooth, but I think it integrates well with the rest of the teeth. I don't know if you agree, but I prefer to be minimally invasive than to do many teeth just to be all the same. And that's the final smile of the patient. And that's a photo that Campanas have taken actually, and I think it's really nice because can you see the flash lines here? That's exactly on the transition line angles, and what we try to do is try to mimic the transition line angles to be exactly the same. That's really important, especially in the centrals. And that's the before and after of our case. And that's another case. That's the initial situation. As you can see, here's a beautiful lady, and actually, she works in Jeddah, Hassan.
Where?
Hopefully, Jeddah. She
What?
works in Jeddah.
Ah, okay,
Jeddah.
Jeddah. Okay.
Yeah. She have moved from Greece there, and she's working there. So that's the initial situation. A lot of attrition, a bit of yellowish color. So what we ask for a bleaching first, and then we're going to do 8 veneers because she wanted to fix a bit of her smile. As you can see, I think the main problem here is the embrasures, which are a bit large, not symmetric, and the incisal lines that are irregular and have adhesions. So this is the final case here. As you can see, we didn't give too much length. The length was okay. We just wanted to make the shapes a bit better and the braziers a bit smaller. And that's the final smile of the patient. And that's the last case for today. That's the case that I told you that I was going to show you. That's a really recent case. So this young guy here, he's actually from Nyland in Crete. And as you can see, he has microdontia on the laterals, very small teeth, and great embrasure, big, and the canines are a bit abrupt, okay? So we said, let's try to make something like this to close the embrasures, give more length, and be more symmetric. So we isolated the teeth. As you can see here, we have some double knots with the floats. We're not going to use to work really aptly on the cervical area, so we don't need to use clamps. So then we place the first layer, which is the enamel. That's the BLL from Ivoclar again, on the 6 anterior teeth. And then we use our matrices to make the mesial and the distal part of the tooth. As you can see here, we have made some boxes of enamel, that's how I call them. So you can work now inside them, okay? So it's really easy because you have the contour. And here, what we did is we were trying to place some irregular lobes from dentine. That's A1 again. Again, I have a big contrast between the dentine and the enamel I use. And in between the lobes, again, we're using the opal. And then you cover everything up with enamel. And right now, I'm seeing that I have big difference in the width of the two sandals. As you can see, this one's much bigger than this one, okay? So it's okay. You still have time to fix this. It's not difficult. You can fix it either with moving your transition line angle more towards the middle of the tooth, or you can drill a bit here and add a bit more composite here with a thin layer of flowable composite. And that's how you can fix it very easily. So right now we have started the finalization, finalization finishing. That's that's the same procedure. So you want to make the contour to be very okay, and you want then to check the primary anatomy, which is the transition line angles, then the secondary anatomy, and then the tertiary anatomy. Okay, so here we're trying to do the secondary anatomy, which are the grooves, as you can see here. And as I'm working, I'm constantly changing my diamonds. So I start with a green diamond, and then I go to a red diamond, okay? So as you can see here, it's already a bit more shiny than it was before. Can you see it? Yes, this is because I'm changing burrs all the time. So as I'm finishing and contouring my veneers, I'm also using smoother burrs and smoother diamonds. And it's really important because you have to do that before you go to silicone cap. You have to have a low speed and very patience at this exactly stage. And this is the final situation, as you can see, and it's polished with the Optogloss. So you have to give too much time on this, and if you give time, you will have a great result. There's no doubt about that. If you have enough time to work and you practice a lot, you will get better and better every time. So as you can see, we have made the form that we wanted in the beginning of the situation. And this is the final smile of the patient, who was very happy, and I was happy with him as well. And that's a big thank you from me. And I hope you enjoyed everything. Hassan, I hope you liked it.
Very nice. Thank you. Thank you, Alex. Thank you
Oh,
so
thank you.
much. I have so many questions from my side, and I know
Okay,
our
okay.
colleagues like they have also a lot of questions. But
That's good.
let me start first. Let
Okay,
me start.
perfect.
Okay. First of all, you mentioned about the time, like time for like 5 to 6 hours in some cases you spent, right?
Yeah, for 60th.
Yeah, for 60 teeth is 6 hours. So 1 hour is like the range for one tooth, right?
Yes, but then I need a second appointment, which is 2 more hours. So it's a bit
But
more than enough.
you spend 6 hours with your patient as a one shot.
Yes, I do.
Oh.
I do. I do. It's
Okay.
really
To be honest,
tiring.
if like in my practice in my clinic, we do it like multiple visits. Sometimes we fix 2 teeth and then we fix another 2 teeth, and like this we do it because some patients they are nagging about if you take too much time, you know.
Can I ask you something? Because I also have patients who are very impatient. Um, are they okay to fix only 2 teeth at a time?
Yeah.
Because my patients, let's say, I can't go out like this. I don't
Okay.
know. That's
Now
the
I get
thing.
it.
That's why I'm,
You
yeah.
you have a point. You mentioned also Optra Scalp. I think this one is from Care, right?
No, it's from Ivoclar.
Also Ivoclar.
Yeah.
Okay, Optra Scalp, the one with the rounded sponge.
Yes, yes, yes. That's the Optascalp pad.
Optra Scalp. It has multiple sizes also, right?
Yes.
Okay, thank you. Also, one thing you showed us, and I think it's the second case, the old nice lady with two
Okay.
tantrums. The
Okay.
old,
Wait, let
yeah,
me go to this slide.
yeah.
This one?
No, I think the second case,
Oh,
the
the second
lady
case.
with the blonde hair
The blonde.
before.
This one. No?
Yes, this one. The two central. You have done something opacity. You increase the opacity of 2 teeth to see the outline form without any
Yes.
translucency,
Yes.
right?
Yes.
Yeah. Here, you did this digitally on a photo on the laptop, or you did this with material. It's not obvious. Yeah.
No, no,
Yeah.
no. It's
It's a
actually from the
composite.
keynote.
Oh,
No, no,
it's a
it's not
key
composite.
thing. So it's
It's a
a
keynote.
digital
I
thing.
took a photo. Yes, it's a digital thing.
Okay, you took a photo, you put it into your laptop, and you put something with higher
Exactly.
opacity. Again,
Yes.
can you rephrase what's the point of this?
Okay, so before it was like this. You have many stains, many translucency. So you can't see the form very visible. Okay. There are many distractions to your visions. So if you
Okay,
do that, you can understand exactly how it looks. So now you can understand what form you're going to create more
okay,
easily.
I got you. I got you. So
Okay.
you are get
Thank you.
rid of the distraction of too much
Exactly.
reflections and too much translucency. You make
Exactly.
it very
Exactly.
opaque. You know the
Yes.
shape. You know the
Yep.
shape of everything.
Exactly. Exactly.
Okay, okay, got you. Okay, we have some question. Let's take it, then we come back to our question. How to make the box that you did by the enamel at the last case, especially in the incisal shell? You use the pellet, you use the silicone index at the last case for the palatal shell?
Yes, yes, yes. I'm sorry I didn't show it. I don't take too much photos sometimes because the
Yeah,
patient
it's 6 hours.
wants to
I know.
leave after. Yeah, it's 6 hours and the patient can go for 7. Sometimes it's 5 hours, so
Yeah, the
sometimes
last
five
case,
hours
the
is
last
much better.
case,
The last
the
case, yeah,
last
I know.
case you have showed
It's
us. Yeah,
this
it's a
one,
very
right?
nice, yeah,
Yes,
very nice pet. Yeah, this picture
thank you.
exactly.
So I use the silicone index and I placed on the index here the composite, and then I use some metallic matrices to do the mesial and the distal part. So we had the boxes of enamel here.
Okay, okay. So it's a silicone index, wax up and
Yes.
silicone index.
Oh, yes.
Okay. We have here Dr. Master Sarah Mortala. Why in many cases not managing the zenith mismatch? You are not managing the zenith mismatch in most of the cases.
That
Why?
that's a really good question. A really good question.
Yeah.
Okay. Some patients don't want to go to a procedure like this. I don't know why, but most of the times it's because of the time.
Yeah.
Because these patients have already passed a month through bleaching, and if they do a gingivectomy or something, then the composite veneers will go 1 to 2 months later. So it's gonna take them a long time. So they say, no, I don't want to do it.
Okay, I got the same thing, the same story here. Sometimes when we tell the patient, we will cut from the gingiva, he will be frightened up. Okay, don't touch it, please. I don't want
Yes,
to.
exactly,
But when
exactly
you do
this.
it without his notice, it's okay.
I know. If
I
it's
do
too
that in
little,
posterior sometimes.
I do it in posterior all the time, really,
Yeah,
and I never ask.
yeah. Dr. Jafar, he also have a question for the case of difference in zenith. I think the same. Yeah, the same. The same
Okay.
as what's the same again. Masa Sarah is asking, what's the rigid material you mentioned for the index? It's a heavy body and
Okay,
light body, additional silicone.
that's the Laborgil Pro 90 from Dreve.
So it's
Do you
additional.
know Dreve?
I don't
Uh,
know. It's not,
I think it's additional. Yeah, I think it is.
it's
And
additional.
the brand name is the Laborgil, Laborsil,
Okay.
Laborgil Pro.
So, but it's
But
additional. We have
it's
another brands here. We can use it.
yes, exactly. But it's cheaper than the dental one because it's for a dental lab, so it's always cheaper.
Yeah. Okay. Okay. I got you. Let me come back to my question. Again, I think that it will be again interesting for you also, guys, to hear this. You bleach in all your cases. You bleach.
Yeah, I do.
Yeah, you always bleach. That
Yes.
why was like to give the patient always a white smile when you do your direct with minimal and invasive. You don't
Okay.
want to press, so you
Uh,
do this. Why?
there are two reasons.
Yeah.
First, because most of the patients want to have a white smile, okay, and I can't provide them a white smile only with 6
Uh,
veneers.
one thing, Alex, flip the camera again. This,
I'm sorry.
yeah,
Okay, so okay, it's
yeah.
much better. So most of my patients want to have a bright white smile. Okay,
Okay.
so if you have to do only 2 or 6 teeth, you can't do 6 white teeth and the rest of them will be yellow, right? So
Yeah,
that's the
right.
first reason. You have to integrate everything to a whiter smile. And the second reason, and I think the most important of all, is that you can do thinner veneers like this because you don't have to mask the substrate,
Okay,
right? You have a
gotcha.
bright substrate, you can do a really thin veneer like this.
Okay, so you don't add
Okay.
too much if you do like bleaching because you have a white basis already.
Exactly, exactly.
And the question here from Dr. Saeed is, but bleaching result doesn't last forever. How
That's
for
true.
how for how long? You're gonna bleach again?
Okay, that's a really good question. Well, bleaching doesn't last long, but the composite veneer also doesn't last the color, right? Because
Yeah,
the composite is not like porcelain, so it tends to attract all the stains and you get more yellows through time. So these do usually go together, the veneer and the bleaching. Most of the time, the veneer is much more yellow than the tooth, the natural tooth, right? It
yeah.
gets to get a bit more yellows. So what do you do then? You just polish the composite and then you bleach the rest of the teeth. So then you have them at the same level again. And eventually you're gonna change them.
Okay, great. Okay, so another question here. Do do you make any modification to the enamel with disc or something, or you just roughen it with
Yes,
sand?
sometimes I do. It depends on the case. If I have a label proclination, let's say, I will cut it with my burr, so it won't interfere with my veneer. But if they're in the right place, and let's say I only have to close the diastema, I only sandblast.
Okay, okay, great. Uh, I have to mention something which I really like about your practice. You really appreciate to structure. You
Yeah,
try
I
always
do.
to bring teeth to more proclined position instead of cutting them and bringing to the retroclined position, and which is very nice.
Uh,
Again, like
oh,
this is a
thank
sacred
you.
This is a sacred part of our bodies. I'm always telling them. It's very sacred to keep like the tooth structure as it is. No matter how much like you need to cut, you need to minimize the cutting, because no matter how you place the material, whatever the brand, whatever the substrate, it's not gonna replace the God creation. This is the point.
That's
So
true.
another question. Okay. Okay. Also, when I treat diastema, I have a problem of having a black triangle. Okay. Well, I know gingiva healing will fill that, but sometimes it remains small gaps. Okay. This is the same thing in posterior, the same story. You can go. Go, Alex, please.
Oh yeah, that's a common problem. So if you have a large diastema, there's no way that you won't have a black triangle. You always do. Okay, you know that. If you have a small diastema, that's much easier. So what do? You want to go more apically. So you use always a clamp to have more retraction of the gums. So you can start your composite a bit more higher, so you don't have a black triangle anymore. And it's not always easy. Okay, so sometimes you have to redo the case to finalize it, to do some corrections, to add some more composite there. What is important for me is to try to close the triangle from the palatal aspect. So you want the palatal to be more close, and then to separate the teeth in a more front position. I don't know if I made that clear. So you have the contact point to be more palatally than usual. Does that make sense?
I got you. I understand.
Okay.
The point is like we do this to bring the contact as close as possible to the bone. This is the point. The same thing in the posterior region. When we do include the contact also, we always try to make the contact in the middle third start from the junction between the occlusal and middle, going down to the middle, to make it close to the bone, like 6 millimeter or less. 5 millimeter is the ideal. As long as it is very close to the bone, 5 to 6 millimeter to the maximum, the gingiva will regenerate again and it will be filled. But if you have a contact like further than 6 millimeter, 100% you will have a black triangle. This is the same story, I think, for posterior and anterior, right?
I think from the paper of Tarnov, that's the paper, isn't it? From Tarnov. Yes.
Yeah. So another question here, in the last case, you don't make palatal shell. Who you add in the size of the composite freehand? Oh, Dr. Sarah, the last case she did palatal shell. She did, and she used the silicone index.
Yes.
How to make symmetrical transition? How to make symmetrical transitional line in both centrals?
Okay.
That's a good question.
That's a good question. Yeah. You always use a pencil to visualize the transition line. So let's say that your tooth is like here. Okay. So you take a pencil like this and you draw the line parallel. So it will go to the most protrudent area. So that's the transition line that you have made. Okay. Now, if you want to reshape it or change it or move it a bit more mesially or distally, you use a diamond burr, which is really small and pointy, okay? And you use a very low speed with a red-coated handpiece, and you drill it with 45 to 30 degrees angle, okay? And thus you can move it more to the middle of the tooth. Now, if you want to do the opposite, so let's say that you want to move the transition line angle more mesially, you use a long burr, which is not pointy, it's rounded, okay? And you try to, how do you say it? You try to drill behind the line and kind of push it more mesially.
Okay.
Does that make sense?
Yeah.
Okay, perfect.
Okay.
I have to show you a video.
Okay. So there's another question: how to locate or how to create the mesial and distals. You use sectionals, right?
Yes, I do.
Yeah. Something it depends on the palatal shell, so it's going to be guiding for the matrix to relocate how my where to place the contact area or where to place the midline between the teeth. So
Exactly.
it's going to be guided. It's going to be guided by the palatal shell. If you do a palatal shell properly, the sectional will go perfectly, and the distance will be perfect 100%. Let me go back to my question.
Mhm.
The third, okay. Where is it? Yeah. Also, you showed like a polishing system. It's Ultra, also from Ivoclar, right?
Yes.
Ultra polishing system. How many pairs? You have shown me two. You have shown two pairs, or only two pairs, right? One for finishing.
Okay, so
Two.
okay. I have to explain this. So the finishing procedure, as I told, takes a lot of time, but most of the time is with diamonds. Because if you use a silicone burr, which is too coarse, okay, it will destroy all the tertiary anatomy. So you want something really small and really smooth, such as a red or yellow diamond, maybe, and a very low speed, and you will go through the surface with very smooth movements to get it smoother and smoother. And then when it will be a bit shiny, okay, just like silky appearance, then you use a silicone cap.
Okay.
Because otherwise you're gonna destroy everything.
Okay, gotcha. And again, like I have something in the veneering, you apply the same story I apply in the posterior. Good adaptation. You really care about adaptation, so you make a good polishing.
Uh, wait, good adaptation of the matrix or good adaptation of
Good adaptation for composite generally,
okay.
like that
Sorry, yes.
for the final layer.
Okay.
If it's you really take care of it, so at the end of the result, you will have an easy
Yes.
way to polish. You will have like
Yes. Yeah,
right?
it's really important. It's the most important thing, maybe.
Okay, this is the same. Okay, so we have another question from Dr. Dimitris. Do you go for perikymata as a tertiary anatomy, or do you prefer a more shiny final polishing?
Okay, perikymata actually is a Greek word. So thank you, Dimitris, for that. Depends. If my patient is really young and has a very protrudent perikymata and microtexture is really vivid and all the stuff, I always do them.
Okay.
But I don't make them too deep. They're too shallow, really shallow. You can see it and not see it at all, you know? Just really shallow perikymata, and you won't have any problem with polishing with that. As long as you don't use a coarse polishing cap on the perikymata.
Okay, I got you. Okay, I understand. So one last question. Maybe it's a little bit personal, but again, we like to compare things. How much do you charge for two central incisor direct veneer? How much do you cost in your away from the taxes and everything?
Okay, I am the worst person to ask for financial advices.
I know.
Really, I'm the worst. So that's approximately 600 euros for two.
200 for euro. It's the same prices here.
Six.
Almost
Oh no,
the
it's
same.
6.
60.
No,
600.
600.
Ah, okay.
600.
No, it's totally different. Okay, totally. This is
Okay,
free of
okay.
taxes or with taxes?
With taxes.
Okay, and the taxes you have to pay about 30%, right?
24 actually, at the end
Okay,
of the year, yes.
okay. So it's still okay. It's too much taxes, but it's a good price if you compare it like to our prices. Again, do you use here, Dr. Abounia is asking, do you use any pigments for the halo effect? I think you has used trans-opal.
Yeah, but transopal is not a pigment actually.
Yeah, it's a white. You use also a white in the
I
halo side.
use white. Sometimes I use the orange. If they have the mesial lobe, sometimes it's more brown or more yellow than the rest of the teeth. Sometimes I use it, but not most of the time. And very, very rare I use blue. I only use blue uh when when how can I explain that?
If you want to
Okay,
increase
when I
maybe the
don't
length of the teeth or something like this.
if I don't want to increase the length
Ah,
because because if I already have a long tooth which has no uh, semi-translucent incisal, okay, let's say that he has an atresion, but it's already too long with the atresion, so the incisal edge is a bit opaque. So
okay.
I can't use an opal trans there because it won't show because the substrate is opaque. So what do? I paint it with blue to make the distinction between the lobes.
I,
And that's the
yeah,
only, yeah, okay, you got it.
I got you. Yeah, I understand. Okay. Uh, uh, like the one of the cases you have shown, it's for a young age patient, the first case, the broken central.
Yes.
You mentioned you treated 4 times or 3 times? 4 times. You just treated again and again and again. Okay.
I
Okay.
couldn't get the shade right.
The
I couldn't
shade.
get it.
Yeah, it's very
Yeah, the
tricky
shade.
dealing with a young age patient for a central incisor. They have the most challenging texture and shade ever because they still have
Yes,
all the
yes.
everything,
It's
all
a
the details is
nightmare.
there. It's a very challenging case. And I know that all the seekers and the obsessed dentists about anterior restoration, they seek for such a cases like a broken central in a young age patient to show their muscles,
Yeah,
but sometimes
I
they don't show it.
know.
Yeah, I'm telling you, I know this story. I know this story.
That's
Dr. Nur
so true.
Salam is asking, okay, well, last question. Dr. Nur Salam is asking, do you prefer etching and bonding before placing the matrix or after?
Oh, that's a good question. And I wanted Hassan to ask you that. Most
You
of
know that
the time,
I put this question a lot in my course.
in the anterior area, I use it before the matrix,
Okay. So,
but in the
and
posterior is
what?
different.
Yeah, it's a totally different story in the posterior, but in the interior, also there is a challenge. Sometimes, even if you are using a rubber dam, if you etch and bond, sometimes when you start to place your band inside, you don't like. There's a risk. Sometimes you have a leak,
I know.
right?
Um, yes, yes. And
Yeah.
that's why I'm doing to do my ligature too strong, and I'm extra careful when I place the matrix. I do it extra gently. I just
Okay.
place it and don't push it too much to be
Okay.
sure. Yeah, I know.
I
It's a
think
nightmare.
it's okay to do before or after in the interior, but in the interior is going to be a little bit challenging while you are placing the band to push everything inside. You need to use like a long bristle brush to force the bonding if you place the band before apply the bonding. So, and if you are using the same technique with like Dr. Alex, yeah, it's better to etch and bond, but you have to have a very good isolation and you have to be very gentle with it. In the posterior, it's a totally different story. We have like the ring is the challenge, another challenge that's being added. So you're gonna ask me before and after. Okay, I will leave this question for you guys until the posterior seminar. Okay, after 3 days, it's gonna be like with Nicholas Campanos, our friend, and okay, like the partner of Alex, and he's gonna be also with Zain Sajjad. Both guys, they will talk about only posterior, and I'll only be moderating. So at that webinar, until that webinar, I will leave this question for you guys. Alex,
That's amazing.
again, thank you so much. Thank you for your time. Really, thank you. Thank you for showing your passion for dentistry. Thank you for giving us this time. I can't thank you enough, but I know that sharing knowledge is a big responsibility for each dentist, like because you have to give everything from the bottom of the heart, and also with a complete honesty about like some scientific base and everything, and you have to transfer your own experience because it's not good to copy everything, but you have to copy the science, but you have to give your own experience. So I really appreciate it. I really appreciate it. Thank you, Alex. Thank you so much.
Appreciate you, and thank you for inviting me
Thank
here.
you.
It's been a
Thank
blast.
you.
Thank you.
Maybe this webinar like is gonna be enough for you guys, not to just to apply direct veneer. It's just only a small part of what's coming. But in each webinar, we're trying to reshape your soul and to recharge your enemy for tomorrow and after tomorrow, and maybe redirect your goal. Sometimes one word can change your future. So focus on it. Thank you again, Alex. Thank you so much. Thank you, my friend.
The pleasure is mine. Bye bye,
Thank you.
Hassan.
Bye bye.
Bye.
Bye bye, Alex.
Bye.
Thank you so much. Thank you.